would like to invite Dr. Madhuvadani, postgraduate from Kanyakumari Government Medical College, for the next case presentation on soft tissue sarcoma. The session will be chaired by Professor Dr. Dayananda Babu sir, Professor Emeritus Surgery from Sri Gokulam Medical College, Trivandrum. I would like to also invite Dr. Pranit Segafil sir, Assistant Professor Surgical Oncology, Kanyakumari Government Medical College, onto the dais.
Okay, start. You introduce yourselves and start.
Good morning, sir. Myself, Dr. Madhuvadani, final year postgraduate, Kanyakumari Medical College. I am going to present a case of a soft tissue sarcoma of right foot. Shall I start?
You can present without PowerPoint, no problem. You know the findings then.
My patient is a 51-year aged male, Sivakumar, who is a security guard, came from Veeramani, some place in Kanyakumari, came to the OPD with the complaints of swelling in the right foot for the past 2 months, complaints of ulcer over the swelling for the past 15 days. He is having difficulty in walking for the past 15 days.
So total duration?
2 months.
2 months, okay.
So history of presenting illness, history of swelling in the lateral aspect of the right foot for the past 2 months. There is an insidious in onset. The patient first noticed the swelling in the swelling of size approximately 2 x 2 centimeter in the lateral aspect of the right foot at the bases of 4th and 5th toes in the plantar aspect, sir, which gradually increased in size to attain the present size of approximately 10 x 7 x 6 centimeter. Later he developed ulcer over the swelling in the sole associated with pain, which is of a burning type. It is aggravated on walking and relieved on taking rest. So he is having the history of bleeding from the ulcer, and he is having the history of difficulty in walking. No history of any trauma, no history of any fever, no history of any swelling elsewhere in the body, no history of any change in sensation in the toes, no history of any loss of weight or loss of appetite, no history of any breathlessness, chest pain, hemoptysis or cough, no history of abdominal pain, abdominal distension or jaundice, no history of any headache, epilepsy or seizures, no history of any previous scars or burns at the site. So past history, he is a known diabetic on oral hypoglycemic agents for the past 4 years. No other comorbidities, no history of any radiation exposure, no history of any surgery, no history of any previous hospitalization for this condition. So personal history, his patient takes mixed diet, bowel bladder habits normal, he is an occasional drinker, no other addictive habits, sleep pattern normal. Family history, no history of any similar illness in the family. An examination, so general examination, patient conscious, oriented in afebrile.
Summarize your history and then summarize your history.
51-year-old male with the complaints of swelling in the right foot for the past 2 months with the complaints.
Plantar aspect.
Yes, sir. Plantar aspect of the.
Any clinical photo?
Yes.
Okay, okay. Summarize your history and proceed.
He's swelling for the past 2 months. It is insidious, which later ulcerates 15 days back. Now he is having pain over the swelling, sir, and occasional on and off bleeding while walking, and he is having history of difficulty in walking for the past 15 days.
Go ahead.
So at this point, what is your expectation, or what do you suspect? Do you have anything in your mind before you proceed with exam?
Sir, initially it is from starting it is a painless swelling. Some short duration. So I think size more than 5 centimeter. So I suspect some malignant tumor, soft tissue tumors, right foot.
So you have malignant tumor in the back of your mind. Anything else?
Could be any.
He's a diabetic.
He's a diabetic.
Diabetic ulcer. You're talking about ulcer swelling.
Osteomyelitis, but no history of fever or discharging from the ulcer, sir. So
one possibility is it could be something related to diabetes.
Diabetic charcoal.
Another thing is because of very short duration and presenting with soft tissue swelling before ulceration again points towards some neoplasia or pathology. Okay.
Vital stable. Examination of bilateral lower limb. After getting
You are suspecting some soft tissue. Always in such cases, you should mention about the performance status, body mass index, nutritional status, all those, and then overall the usual the pallor, icterocinosis, those things. But always mention about performance status in all malignancy, BMI in all malignancy, nutritional status, all those things you should mention. Make it a habit.
How do you assess performance status?
ECOG score, Kanofsky scores there. For malignancy, ECOG score, European Cooperative Oncology Group scores 0 to 6. 0 normally performing. For 1 is performing normal activities but difficulty in strenuous 6.
Okay. Why performance status is important?
For the post-op
Why do you want to know the performance status? And BMI?
BMI, nutritional status, a general condition of the patient, whether he is fit for the treatment.
So you need to know whether the patient will be fit enough to undergo surgery and chemotherapy if at all, if it turns out to be malignancy. So you need to assess the
performance status.
Performance status beforehand.
After getting proper informed consent, the patient is asked to expose from the umbilicus up to lower limb. Left lower limb appears apparently normal. Gait, the patient walks with his right heel. Attitude of the right lower limb. On standing, there is mild dorsiflexion of the right foot. Right great toe is presented with valgus deformities. The clinical image of the patient on standing, sort of the swelling in the foot. So local examination of the right foot. On inspection, a single irregular well-defined swelling with irregular well-defined margins of size 10 cross 7 cross 6 centimeter in the lateral aspect of the sole of the right foot with fullness in the fourth interdigital space on the dorsal side, sir. So extend 5 centimeter from the medial border of the foot medially anteriorly up to the base of the fourth and fifth toes, laterally up to the lateral border of the foot.
It is coming to the dorsum.
Yes, sir. Fullness is present in the intercostal space, sir. I can see fullness. Compared to the left foot, I can see some fullness in the...
Which space?
Interdigital.
Interdigital space.
Which space?
Fourth.
Fourth. The swelling appears to be more towards the big toe. I don't know. You are telling more towards the little toe.
So swelling more towards the little.
More towards the?
No, on the dorsal aspect, it is more towards the big toe. Look at that picture.
The second picture, we are any other picture, then it will make it clear. For me, it is looking more towards the big toe side. Oh, your finger is where? On the big toe side, or whose finger is that?
Front.
Okay. So it is more towards the
Tip is towards the greater toe, sir. Great toe, sir.
lateral. More towards the lateral part of the foot. Okay, go ahead. And it is coming to the dorsum.
Yes, sir. Interdigital space.
Okay,
Expansive
okay.
floor.
Right. Okay, go ahead.
Surface is basalated. The skin over the swelling. The ulcer of size 4 cross 4 centimeter present over the swelling in the sole, the plantar aspect, sir. It is
Ulcer is over the swelling or not?
over the swelling, sir.
So you say that it is over the swelling. Right.
Okay, sir. It is having a irregular well-defined margins with floor is covered with the pale granulation tissue, no active discharge, sir. And palpation, inspectory findings are for size, shape, extent are confirmed, no localized rise of temperature, and the swelling, tenderness present in the medial aspect of the swelling in the sole. On palpation, consistency is firm, It is a fixed swelling. Mobility is restricted in all directions. Skin is not pinchable and it is not pinchable and fixed to the swelling. Ulcer is on examination of the ulcer. It is the base is fixed to the swelling. Doesn't bleed on touch. Peripheral pulses of both lower limb palpable and normal.
So the swelling is fixed to what? Swelling is fixed to what?
Fixed to underlying muscles.
Fixed to the bone or muscle? Or
Muscle.
no movement at all.
Yes, sir.
No movement at all.
Yes, sir. It is hard. Already the sole skin is already thickened, sir. So it is no movement, sir. It is already fixed.
Go ahead.
So by examination of the bilateral inguinal region, no significant lymphadenopathy. Examination of external genitalia normal. Systemic examinations, CVSRS abdomen normal. Digital examination normal.
No. The pulsations.
No visible pulsation.
No. You don't have any vessel distal to that?
Distal to the vessel.
No.
No distal.
Small vessels may be there. I don't know. The color is any pressure effect by the tumor?
Capillary. No, sir.
Nothing.
No.
Right. Movement of the ankle joint.
Movement of the no restriction of the movement, sir. Ankle joint movement.
Ankle joint is free.
Yes.
Right. Yes. Why a digital rectal examination in this case?
Soft tissue tumors are
We'll go to the
associated with the germline mutations of familial adenomatous polyposis core.
Oh, along with FAP.
FAP it can be. So any bleeding.
Right. What is that syndrome called?
Gardner's.
What
Yes.
spelling?
Sir?
What is the spelling?
Gardner syndrome.
Gardner. Any other syndrome?
Associated with soft tissue sarcoma, sir.
Yes.
Neurofibromatosis type.
Neurofibromatosis.
Von Recklinghausen, sir. Leaf Romani.
Leaf Romani. Right. Yes. Okay. So I think it will not go to the pouch of rectovesical pouch. It will not go, definitely. I don't know. That is why I asked what is the purpose of that. Right. What is that 1.5?
Sir, the inguinal nodes palpable, sir, but not significant, sir.
But you said initially not palpable.
No significant lymph node enlargement.
So what is the significant lymph node?
Inguinal node size more than 2 centimeters, sir, with hard inconsistency, fixed nodes.
2 is cut off. I don't know. Inguinal node 2 is the cut off criteria. How many nodes are there? The inguinal region.
Normally,
You are patient. How many nodes are?
Palpable nodes, 2 nodes.
2 nodes are there. Anyway, what are the sarcomas which will produce lymph nodes?
Rhabdomyosarcoma.
Yes.
Angiosarcoma.
Yes.
Clear cell sarcoma. Epithelioid sarcoma.
Epithelioid. Synovial sarcoma.
It will.
Yes. So, can it be a lymph node metastasis from the sarcoma or a lymph node as a result of the ulcer, infected ulcer?
It could be a.
Any feature of infection for the ulcer?
Ulcer.
Yes or no?
Ulcer, it could be a.
Two things. Whether there is any feature of malignancy in the ulcer. Second is any feature of infection of the ulcer.
Feature of malignancy is there, sir. Floor is with granulation tissue. This flesh.
What are the features of malignancy in an ulcer?
Edges.
What type of edge?
It will be everted edges.
Everted edge. Yes.
What type of ulcer do you expect in soft tissue sarcoma?
Mostly, I expect due to the pressure, thinning, sarcoma infiltrating the skin. Pressure
necrosis.
necrosis.
Pressure that causes the skin to peel off and go for necrosis and ulceration. Okay. So in that case, how will be the ulcer?
Edges
Will it be everted?
No, sir. It will not be everted, sir. Pressure, no, it will be flushed to the surface.
Go ahead. That is, go ahead. What is? Come to the conclusion. Which system you examined first?
Sir?
Which system you examined first? Why CVS first? In a case of suspected sarcoma.
RS.
Generally, we will examine the chest or abdomen, not CVS. Yeah, this mistake is happening every time. All the students from UG days onwards to S1, S2. What is the significance of S1, S2 in this case? Nothing. Isn't it? Mixed diet. What is the significance? What is mixed diet? You also said.
Both vegetarian and non-vegetarian.
That is called non-vegetarian. There is some attempt to correction should be there. Inspectory. There is no fine term as inspectory. Inspection findings. Always you say inspectory findings. Okay. So coming to your the chest, I feel that abdomen or chest should be the first, not the CVS. Priority should be abdomen for liver mets. Usually the limb sarcoma will go to
Lungs.
lungs. The abdominal sarcomas will go to
Liver.
liver. That you should know. So go at least to the abdomen or lungs. Go ahead and give the diagnosis.
A case of swelling of the right foot, most probably a malignant tumor of soft tissue or
Right foot. Most probably malignant tumor of soft tissue. Like
undifferentiated pleomorphic sarcoma.
undifferentiated. What is why undifferentiated pleomorphic sarcoma?
Most common.
Common. You are thinking the old terminology of MFH. It's a pathological diagnosis. Better is, I just asked what type. But soft tissue sarcoma is enough, not pathological diagnosis.
Okay.
What is the origin of soft tissue sarcoma?
Undifferentiated mesenchymal stem cells.
Mesenchymal stem cells. That is why even in skeletal muscle region you get leiomyosarcoma. Possible because origin is undifferentiated mesenchymal stem cells. But the diagnosis better not to tell like that. Diagnosis. Okay. Any questions regarding?
Why do you say it is malignant?
Any swelling more than 5 centimeter, shorter duration, tumor followed by ulcer, pressure necrosis, ulcer followed by development of the ulcer.
So very good. So any deep-seated swelling, deep to deep fascia. Here you cannot specify the fascia. So any swelling which is deep to deep fascia, more than 5 centimeter, it is probably possibility is to be malignant. And as you said before, the ulcer is not suggestive of malignancy. It is just a pressure necrosis that has caused the ulcer. Okay. So it is the pressure necrosis that has caused ulceration. Okay. So one thing you have missed is, is it necessary to examine the popliteal fossa?
Yes.
So popliteal fossa is also a draining station. So it is located in the plantar region. Okay. So you should examine the popliteal fossa before you examine inguinal nodes. And as you said, you are right. Any node more than 2 centimeters in size, round, hard, it may be fixed or may not be fixed, is a significant node in an inguinal node. In all other cases, any node more than 1 centimeter is considered to be significant node. Okay. So here you have got a swelling, soft tissue swelling, which presented initially as a swelling and later on
ulcerated,
went in for ulceration and with no nodes. So your clinical diagnosis is a soft tissue tumor. A better way of presenting is it is a soft tissue tumor, probably malignant. Okay. So what is the next step you are going to do?
Investigations to confirm the diagnosis. I will go for imaging with imaging. See MRI, sir. MRI of the right foot. Then followed by a biopsy, a core needle biopsy, sir, for tissue diagnosis.
What is the problem if you do a biopsy directly?
It will distort, architectural distortion and anatomical distortion can be done.
So always
do
so in any soft tissue tumor, always do imaging first,
followed by biopsy,
because that because by doing imaging you will come to know the exact tumor. Some part of the tumor may be necrotic, cystic, and some part will be having a soft tissue. So you will know where to do the biopsy exactly. So that is one thing. Another thing is, if you do the biopsy prior to imaging, there is a possibility of interference. So it might bleed, and that might intervene with your imaging report. So always do imaging first, then go for a biopsy. So as you said, the imaging of choice in an extremity soft tissue sarcoma
MRI
is MRI. So MRI has a better delineation in any soft tissue. And what is the main concern in your case? It is close to your metatarsals. Okay. So you need to know whether they are involved or not. So in that case, a CT will definitely help you. So I would prefer both MRI and CT, because MRI will tell you the extent of soft tissue component, and the CT will tell you whether the bone is involved or not, whether periosteum is involved or not. Okay. So that is about imaging. And what type of biopsy would you prefer?
Core needle biopsy, sir.
Core needle.
True cut to core needle biopsy.
It's already ulcerated.
Sir?
What size? Core needle what size?
14 gauge.
Yes?
What is the size of the needle?
Tell me, maybe correct.
14 gauge.
14 gauge. Okay.
Why not 16 or 18 or 21?
Sufficient.
60,
Because
yeah.
grading is important in the
Yes.
stage.
So you need to establish the histological diagnosis as well as the grade. So for you to establish the histological diagnosis and grade, you need better tissue representation. Okay. So you need a bigger specimen. So always do with a 14 gauge needle.
Apart from grade, what else you will gather by doing a core biopsy?
We can do immunohistochemistry.
No, immunohistochemistry is important. Yes. What is the purpose of immunohistochemistry?
We can differentiate the cell of origin.
What type of cell of origin is important? Because you need to know whether it is a small round cell type or not. That is a basic requirement. If it is a small round cell type, you will go for chemo first. So that is the reason. Before your surgery or whatever you are planning, need to know whether it is small round cell or not.
Which tumors have small round blue cell?
Ewing sarcoma. Ewing sarcoma, clear cell.
Rhabdomyosarcoma is there.
Alveolar abdomen.
alveolar, so many are there. So if it is your diagnosis is that, then you first do chemo. Otherwise, in this case, always if for bone, always CT is better. For soft tissue MRI, this you should know. Basically, for bone, always
CTs.
For soft tissue,
Yep.
MRI. And then, so the report is soft tissue sarcoma, maybe liposarcoma, or maybe one of the undifferentiated, maybe your diagnosis. How do you proceed? That is the report of the core biopsy. How do you proceed in this case? Your patient.
This
Yes.
grade of the tumor.
Grade is why grade is important. One is prognosis. Second is it is included in staging. So will you do any staging workup or not in this case?
Yes.
That is why I am asking what you do.
CT chest I have to do.
Always you should do CT chest, abdomen and pelvis. Okay. So you do CT. Staging. What is the staging? At least T wise. What is the staging?
Sir,
T size. What is the staging? What is T1?
T1 less than or equal to 5 centimeters, sir.
T2?
5 to 10 centimeters.
T3?
10 to 15 centimeter. T4 more than 15 centimeters,
Okay.
sir.
So at least T size you know, then the grade is also included. So after knowing grade only you will be able to. But you can rule out metastasis by doing a
Staging. CT.
magic.
Chest.
So that is the aim. And then followed by what do you do? What do you do?
Treatment plan.
What treatment do you offer? Your
We'll
patient
discuss
is there.
We'll discuss with the tumor board, and will I offer a radio. I will prefer radiotherapy for this patient more.
Why?
Because it is a while local excision, it will be
If
very
you want
difficult in
to
this.
save the limb, you have to do something more. Limb sparing attitude is there nowadays there. So if you want to spare the limb, you have to go for, in this case, you have to go for
Radiotherapy.
radiotherapy. Or
Followed.
chemo is there or not?
Chemotherapy is there, sir, but
What is the chemotherapy of choice?
doxorubicin, dacarbazine, ifosfamide based regimen.
Made rich. Okay. I don't know what the medical oncologist is preferring. So you have to, the tumor board, and then they will decide whether, especially what is the problem with anti-radiotherapy? Healing problems are there.
Healing problems, so plastic flap reconstruction will be needed.
So basically from your imaging you should assess whether it is resectable or not. Okay. So whether you can get away with a good R0 resection, because what is R0 resection in soft tissue sarcoma? What is the margin would you give?
1 to 2 centimeters
Yes.
is best.
So ideally it should be 1 centimeter. You should never look at the, when you resect, you are not supposed to look at the tumor. That is what we say. So ideally 1 centimeter margin is necessary. So you, based on the imaging, you should assess whether that is possible in this case. If it is not possible, if it is not resectable, you cannot achieve R0 resection, then you should opt for some neoadjuvant therapies. Okay. So when you are in doubt, if you cannot achieve a R0 resection, you can give a preoperative radiation. So what are the advantages of a preoperative radiation?
It will cause yes.
See, unlike any carcinoma, sarcomas, they push, they have pushing borders. Okay, you call it as pseudo capsule. So when you give radiation, these pseudo capsules will be
acellular. It will be
they'll become acellular, and you can resect them easily after surgery. As sir rightly said, it is the problem with preoperative radiation is wound healing will be bad when you compare to an upfront surgery. So in that case, when will you take up the patient for surgery after a pre-op RT? maybe after 6 weeks.
6 weeks.
So you wait for 6 weeks, wait for the radiation reactions to come down, and then take the patient for surgery. Okay. So this is what you do when you think it is unresectable, and you can give preoperative RT. So there will be situations when even with resection you cannot give a functional limb. So in that case, what will you prefer? So even if you get away with a soft tissue margin, you cannot give a functional limb for the patient. In that case, what can you do?
Can do amputation.
You can go for a
Suggest
amputation. So you should assess preoperatively. Ideally you should have put the MRI and CT findings for discussion. A PG has to know whether you are going to operate or not. Okay, it is not the tumor, but it is you who should decide whether you are going to operate it or not. So imaging plays a vital role. Another thing is, suppose your core needle biopsy is negative. The first time you are doing, it comes as negative. What are you going to do? So is there any role of incision biopsy in your case? It is already ulcerated. Is there any role of incision biopsy?
Yes sir, I can do, sir.
What precautions will you do when you go for incision biopsy?
I have to put an incision. It should be included in the future resection. Then I have to achieve adequate hemostasis, and no drain should be kept. Biopsy taken. In size less than 3 cm tumors, I can do excision biopsy.
Okay, so the problem with incision biopsy is it should be done very carefully and under supervision. Okay, so you should achieve perfect hemostasis, and your incision should be in line with the future line of incision. And take precaution. Don't develop any flaps. Go straight away to the tumor, take a biopsy, and come out. What is the advantage of incision biopsy over core needle biopsy? Why still we are talking about incision biopsy when you have core needle biopsy? As you said before, you need a better chunk of tissue for establishing the subtype and grade. Okay, so with core needle biopsy, you can get tissue. Only a very little amount of tissue. So incision biopsy can give a better tissue. That is one thing. What is the role of FNAC? Why can't you do FNAC?
You can do that only it will say we cannot identify the subtype of the.
See, the role of FNAC is
only in recurrent tumors and lymph nodes.
Okay, so for you to establish it histologically and for you to know the grade of the tumor, FNAC is of no use. Okay, so always do
core needle biopsy or incision.
And that too, what we insist is always do image guided core needle biopsy, because the tumor will be heterogeneous. It will not be homogeneous. It will not be soft tissue throughout. There will be areas of cystic degeneration. There will be areas of necrosis. So there is a possibility you can end up with a negative result in your biopsy. So always do image guided biopsy, that to core needle biopsy. Okay.
What is pseudocapsule?
Usually soft tissue sarcomas are expansile tumors. They will compress the surrounding regions, causing a zone of compression followed by a zone of neovascularization. Reaction.
What is marginal excision?
Marginal excision, we are removing along with the pseudocapsule we are removing, sir, without giving any margin.
So the pseudocapsule, what is if suppose you go inside the capsule, what do you call it?
Intralesional excision.
So those things are what is the purpose of this wide excision?
Wide excision,
because tumor will come out of this pseudocapsule. At some areas the tumor will, and they found that it will not go beyond 8 mmR. So that is why your 1 centimeter wide excision. So always remember that the tumor is not limited to the pseudocapsule. It will come out of the pseudocapsule. That is the reason.
Is it just a wide excision, or you say one more word you add?
Limb functions.
Is it 2-dimensional wide excision?
3-dimensional in depth also we have to go.
What are the areas when you sir was asking you for the staging or the assessment? You said CT lung, CT abdomen, CT pelvis is mandatory. Any other area you will look for?
Brain, spine.
You have done a histology. Histology has proved particular type of cancer, particular type of sarcoma. Will you look for any particular site?
Yes, sir. In case of mixed liposarcoma, sir, I will look for a brain.
Brain.
Brain alveolar sarcoma, sir. Mixed, I will look for spine.
If it turns out to be, if you are thinking in terms of neurofibroma,
Spinoid.
to rule out what?
Sir? Metastasis. See, neurofibroma, I look for sphenoid dysplasia, optic gliomas, involvement of the tumors.
What is MPNST?
Sir? Malignant peripheral nerve sheath tumors, most common associated with neurofibroma type 1.
So what is the difference between compartment excision and wide excision?
In compartment excision, it is previously done, and you have if any muscle is involved now, we will remove it from the origin to the incision, sir. So it will be radical. So the wide local excision is better comparable.
So what is the problem with wide local excision when compared to compartment excision?
Risk of recurrence.
So previously the problem with soft tissue sarcoma is there is a very little risk of skip lesions. Okay, that is why you need to do MRI of the entire. Suppose if it is in the thigh, you need to do the
MRI.
imaging of entire thigh. Okay, there is a possibility of skip metastasis. So always you do, it was implicated before you do a compartment excision, but now because compartment excision it is functionally debilitating. Okay, so as surgery is evolved, they have shrink the surgery to wide excision, so there is a possibility of recurrence with wide local excision. So in that case, when you select wide local excision for any soft tissue sarcoma, it should be accompanied with adjuvant radiation. Okay, that is must. So what precaution will you do when you do a wide local excision? You are planning for radiation. Okay, so what will you do intraoperatively?
Mark.
How will you mark? Why do you need to mark?
Keep my close, talk louder.
For reaction.
So you are doing wide local excision. The radiation oncologist will not know where to irradiate. Okay, he will not know the proximal and the distal, the medial and the lateral margins. So you need to mark for them to identify the extent of the lesion which was present before. Okay, so how will you mark? How will you mark this surgical site?
Titanium.
I am not asking how will you mark the specimen.
Mark titanium clips margin is.
Simply you can use your the clips you use for cholecystectomy. Okay, you can use that clips. They are titanium clips. So you put the clips superiorly, inferiorly, medial and lateral and depth. Okay, so the radiation oncologist will get to know an idea where the tumor bed was, and they will give a additional tumor bed boost. Okay.
Because sarcoma is a very, if that's a case is there, definitely it will be kept for your examination. That is why we incidentally wanted to prove that the original list was not there. So any questions you have on the sarcoma?
The ulcer, the raw area also, you can put needles, iridium wires before closure. If you are thinking that the excision margin is not it is not R0, you can put iridium wires.
Sir?
What therapy?
What is that? What is that therapy?
Intralesional brachytherapy.
Brachytherapy. So you can try brachytherapy if you feel that the excision was not. In addition to putting your clips, brachytherapy is also useful, right?
What all are the difference you know from the retroperitoneal sarcoma and peripheral sarcoma?
Retroperitoneal sarcoma, most common type. In staging wise, nodal involvement which if node is positive, retroperitoneal sarcoma is
In your approach or in your diagnosis or in your progression of the tumor, retroperitoneal sarcoma and peripheral sarcoma.
Metastasis common.
So where it metastasis? Retroperitoneal sarcoma.
Retroperitoneal mostly to the liver, sir. Yeah, extremity sarcomas mostly to the lung, sir.
Okay, you said staging. What is the difference in the staging in abdominal and?
If the node is positive, na, it will in periphery sarcoma it will go for stage 4, sir. But in retroperitoneal sarcoma it will go for stage 3B, sir.
Stage 3B. What is the commonest retroperitoneal sarcoma? What is the common in peripheral, sir?
Commonest retroperitoneal liposarcoma, sir. In periphery it is undifferentiated pleomorphic sarcoma or MFH.
You know, as a student, please understand, if you are not telling the answer and telling only the half of the word,
Malignant fibrous
the
sarcoma.
entire sentence, entire word should be audible to the examiner.
Okay.
Okay.
MFH or malignant fibrous histiocytoma or undifferentiated pleomorphic sarcoma, sir.
Suppose the sarcoma is in the breast. Is it a peripheral sarcoma or?
It is peripheral, sir.
So how will you stage that?
Like the peripheral size.
Suppose Kaposi sarcoma.
Staging will be different.
Different. Desmoid tumor. Is it a sarcoma?
Yes, sir. Sarcoma, sir.
How will it stage?
Different staging.
Different staging. Okay.
So when will you do amputation in an extremity sarcoma? When will you do amputation in extremity sarcoma? If we cannot provide adequate margin
and if even if we do not there is no any function preservation, we can do amputation, sir. One joint above.
Objective in one line. Your objective of doing surgery and what is the goals?
Limb sparing, function preserving, margin free, wild local excision, sir.
So when you will do amputation?
If we cannot preserve the function of the limb.
So suppose the nerve is involved.
Nerve is involved, na, we can do resection. We can lose the nerve, sir. We can do nerve graft can be.
So without nerve you can get the function.
We will give any braces for the movement of the joints, foot brace, stability, knee stability, braces.
Artery is involved.
We can provide a graft, sir, for the arteries.
Bone is involved.
Bone is involved. No, now bone grafts. Bone involved.
So basically a functionless limb, you need to do amputation. Suppose if the patient has got a metastasis somewhere in the lung or liver, will you go for amputation? Other indication is a painful limb.
Painful.
Okay. Any painful limb, you need to go for amputation. Suppose if the patient has got a metastasis, will you go for amputation?
Metastasis. Painful or no? If he is having pain, we can do.
Tell yes or no, ma. Don't talk with yourself. Please, yes or no.
So if the patient is metastatic, don't go for amputation. Okay. Put the patient on best supportive care.
So you will amputate at that level or?
One joint above the tumors.
So thank you, because she was asked to present this case only at the last minute. So I'm sure that she has done well, and thank you for your presentation.
Thank you, sir.
Thank you, sir.
Yeah. So for dermatofibrosarcoma, the margin should be little higher. It should be 3 or more. Okay. So for any soft tissue sarcoma, it is ideally 1 centimeter all around. So that too, if you are close to any vital structures, for example, if you are close to the nerve or if you are close to the vessel, you can get away with the perineurium or the adventitia of the blood vessel. Okay. So what we say in oncology is, if you remove the periosteum, suppose if the tumor is close to the bone, if you remove the periosteum, it gives you 5 centimeters of margin. So if you remove the fascia is not involved. If you remove the fascia, it is equivalent to 2 centimeter margin. Okay. So that is how you proceed. So you need to have a better idea in imaging where the tumor is and which structure you are going to remove. You should plan it before you take up the patient for surgery. Ideally, if the tumor is situated deep in the intramuscular plane, 1 centimeter margin is enough.
This is called the Kawaguchi principle, right? That you know, right? What was the question? Role of MRI. Wherever you suspect the problem is soft tissue, MRI will be better. There is no bone there. So what is?
So why MRI is not indicated in abdomen? The problem is it's the problem of air in the bowel. Okay, you cannot delineate the things properly. So that is why we advocate CT for retroperitoneal sarcoma. Okay, a better 64 or 128 slice CT will give you better idea where the tumor is, where it is extending to, which organ you should remove. CT will be informative in a retroperitoneal sarcoma.
Okay, thank you, Professor Dayananda Babu sir and Pranit for this.